Hello and welcome. The purpose of this video today is to educate about prostate cancer. In particular, go over evidence-based studies of prostate cancer in gay and bisexual men. And the purpose of this is that it's not going to be 100% all-encompassing, but it is a starting point to start to understand some of the issues that arise after prostate cancer and prostate cancer treatments so that you can go to your doctors a little bit more informed about some of the knowledge and information out there. So let's get started. So, prostate cancer, what every gay and bisexual man should know prior to getting treatment. So, who am I? I'm a reconstructive urologist who uniquely studies LGBT issues in urology. I'm from Indianapolis, Indiana, and I went to medical school at UCSF and did all of my training and fellowship at UCLA. So, I think the first question that some people have when they're diagnosed with prostate cancer is some people are unfamiliar with what even is the prostate. So, let's just start there. And here is a picture of somebody kind of sliced down the middle here. Here's the front of the pubic bone, and here's the rectum where people poop. And here is the prostate. And the prostate is normally the size of about of a big walnut, and it sits right underneath the bladder. And what the prostate does is it actually creates some of the fluid that is in semen. And as you guys all know, urine, which is stored in the bladder, and semen, it all leaves the same tube. So the prostate sits right underneath the bladder and is connected to the urethra here down below. And the urethra actually passes through the prostate itself. The prostate, you can actually feel the prostate with your finger if you were to put your finger into someone's rectum. And, it's about yay big, yay deep inside there. Prostate cancer is when the gland cells of the prostate actually replicate too quickly and they form, a cancerous piece or tumor here. And cancer cells in the prostate are usually formed on the periphery of the prostate gland and not usually in the middle, which is why symptoms for prostate cancer usually do not come until the prostate cancer is of a very late stage. So most prostate cancer nowadays is actually caught by screening. Now, when somebody hears the word cancer, they often think of, imminent death or, time too quick to the cancer to grow and cause problems, chemotherapy. But I want you to realize that prostate cancer is not the same as other cancers that you hear about in the news. So this is a good slide that shows the number of people who are diagnosed with a certain cancer versus the number of people who died from that cancer. So if you can see something like lung cancer, almost half of the people who are diagnosed with lung cancer eventually die from that disease. And pancreatic cancer, there were 66,000 cases of pancreatic cancer and 51,000 of those patients died. So pancreatic cancer is a very quick, fast-growing cancer. Now, if you look at prostate cancer, there's about 300,000 estimated new cases where 35,000 people died from prostate cancer. So not all cancers are sort of created equally, and we tend to think of prostate cancer as a slower growing cancer. However, not all prostate cancers are that slow, so you need to talk to your doctor about sort of your grading of your prostate cancer to determine how aggressive it is. But in general, if you are diagnosed with prostate cancer, you usually have time, in the order of months even, to figure out how you want to deal with it and how you want it to get treated because there are options. This is a slide that looks at cancer epidemiology. So, like, how common is it? And look at here. So, if you look in the 1990s, we found a lot more prostate cancer. And the main reason for that was this was the advent of the PSA screen. And as we all know, PSA is not a perfect screening tool, but it is used nonetheless to help us find prostate cancer. And, one thing that we realized was that we were treating a lot of cancers unnecessarily. Because you could see here that the spike of prostate cancer went up in terms of diagnosis. But on another slide, which I don't have here, you could see that cancer mortality really didn't change. So it means that we were treating prostate cancer um, too aggressively. And I think we have learned over the course of the last 20 to 30 years which prostate cancers really need to be treated and which of them actually can you just watch. So that's an important concept in prostate cancer that you usually don't see in a lot of other cancers. This whole idea of just watching it. So the next part of the talk, which is the meat and potatoes here, is really 10 important studies that I think are very important for gay and bisexual men to at least know a little bit about prostate cancer. Now, like I said at the beginning, this is not a all-encompassing talk, but these are the ones that I have found very important and they bring up important concepts that people should understand and know about before they get their prostate cancer treated. Number one, this is probably the most famous, one of the most famous prostate cancer trials, and it's called the PROTECT trial. And this is where men with prostate cancer, localized prostate cancer, meaning that cancer was only in the prostate gland, which is where majority of prostate cancers are. And this was actually done in Europe, in the UK. And I think it started in the 80s or 90s, maybe a little bit later, but they basically just randomized men to active monitoring, prostatectomy, or radiation. And then they followed them for the course of, 10, and this study was the 15-year follow-up for these patients. And if you look at the overall survival, so how many of these men were still alive 10, 15 years later, you can see that at the 10-year mark, 98, basically 99% of the men were still alive. So again, this tells me that prostate cancer survivorship is extremely high. This is not the same as some of those other more aggressive cancers. And if you look at the 15-year survival, even the ones who were randomized to active monitoring, now some of them did end up getting treatment later on, but at the beginning they were just randomized to active monitoring. 97% were still alive versus 97 in the prostatectomy group and 97 in the radiotherapy group. So this is why we say often, when you have choices for treatment in terms of prostatectomy versus radiation, the difference of mortality rates, there is not any that we could find. So here's another trial. So, I mean, another figure from this same study. So, if you look at metastasis-free survival, so that means how long throughout that 15 period of time did people have no metastasis, which means that the cancer did not spread. You can see that in the active monitoring group here, there was a higher degree of metastasis in that group compared to prostatectomy or radiotherapy. So we do believe that treating the cancer is usually the right way to go. Um, but whether or not you got prostatectomy or radiotherapy, there was no differences in metastasis. Now, one caveat of this trial is that they did include a lot of people with very low risk disease. So you have to take that into account. For some of these patients, we would probably put a lot of them on active monitoring these days. However, I think this is a good proof of concept for people out there to understand the idea that prostate cancer is a slow growing cancer. The second study is this functional outcome study, which was published in JAMA, which is the Journal of American Medical Association, which is one of our top journals. And this looked at functional outcomes after localized prostate cancer treatment. So they actually measured people's quality of life after certain treatment options, and then they followed them over time. So they had people fill out surveys before and after treatments and then followed them. And this was what's really cool about this study is that they included 2,000 participants with localized prostate cancer. Now, so what did they find? So the first one, let's look at erections. So again, the prostate is right under the bladder, and all the nerves that go to the penis kind of wrap around the prostate. If you had a radical prostatectomy, which was the red line here, okay, and these two blue ones is radiotherapy, and the kind of the orange line here is active surveillance. So it is very well known, and this has been repeated in other studies too, that right after you have a radical prostatectomy, meaning the prostate is removed, that's what us urologists do, there is an initial big hit on erections. So erectile function is not so great at the beginning, probably for the first few years. If you look long period of time, again, about 5 years out or so, there was really no major changes of erections sufficient for intercourse. But for sure, radical prostatectomy was worse for erections for the first year or two, and then maybe it kind of comes together. Problems with urinary leakage. Again, radical prostatectomy was worse for urinary leakage across all time points. So there is more urinary leakage, I would say, for sure, with radical prostatectomy versus radiation therapy. Another problem here is frequent urination. So they looked at that across time, and you can see that radiation, external beam radiotherapy, it took a real hit at the beginning, and then later on was the same as the other groups. And I think that's common in my practice as well. So people who have had radiation for their prostate do have some irritative lower urinary tract symptoms that typically get better with time. Then the other one was problems with bowel function. So what would that be like? So, bowel irritation or bleeding or painful bowel movements, etc. There wasn't a whole lot of differences between the groups at the beginning. And if you looked at some of the data later on, there was some significant differences in the brachytherapy group that had a little bit worse bowel function over time. Brachytherapy is where you put seeds into the prostate, which are radioactive, and that helps treat the cancer. So the first two studies kind of give us the big picture. What are some side effects that occur during prostate cancer treatments? And what are some areas or some, side effects that are more common with surgery versus radiation? But now I'm going to get into the more specifics of how this impacts gay and bisexual men. And the third interesting study is this preservation of manhood study, and this was published in the Journal of Health Psychology. And if you look at the date here, this was actually published in 2002, so quite some time ago, but really it was one of the first studies that I could find where they actually talked to some gay men who had prostate cancer and got their perspective. One thing you have to realize in a lot of the prostate cancer literature at the beginning, it was all about cancer control. What do we do to stop the cancer? Which I think is important, but again, we're realizing that the survivorship matters just as much. So, how are people living after the prostate cancer is controlled, and how do we make that better? So, anyways, this study is called Sexual Dysfunction and the Preservation of Manhood: Experiences of Men with Prostate Cancer. And it was one of the earliest studies to assess quality of life after prostate cancer treatments by sexual orientation. And what did they do? They literally just interviewed people. They interviewed people and they asked them about how their life was. And four of the men were gay men. And I think this is an interesting quote that I wanted to read. For single men in particular, there was always hesitation and apprehension leading up to the moment of disclosure. One gay man was concerned that if he were openly to discuss his prostate cancer and the treatment side effects with a new lover, that he would become the object of ridicule and slanderous gossip. So the concepts here are one of this moment of disclosure. So you've had prostate cancer treatments, you have some degree of changes in your sexual function. And how is it people feel like they have to disclose this before meeting with a sexual partner? And that whole aspect is can be very troubling to some people, understandably so. And one man again uses this word ridicule, like this idea that like I'm not fully functioning like I used to be before, and this idea of ridicule and the psychological distress that it could cause. Let's look at this study number four. So this was a big survey-based study where they measured people's responses on a survey, and they actually looked at 124 gay and bisexual men with prostate cancer, and they compared that to 225 heterosexual men as their controls. And the study is called Health Related Quality of Life, Psychological Distress, and Sexual Changes Following Prostate Cancer, a comparison of gay and bisexual men with heterosexual men. So, this is people who had their prostate cancer treated, and we, at one time point after their prostate cancer, surveyed them. And we surveyed them with a bunch of instruments and basically tried to compare was there any differences that we noticed between the gay and bisexual men and their heterosexual peers. I think the demographics are important here. You know, if you look at um, the percentage of men who were single, so 50% of the gay and bisexual men in that study were single versus 14% of heterosexual men. And you can imagine that if you are single and you are recently diagnosed with prostate cancer and you are going to have treatments that impact something like sex, like urination, etc., I can imagine that it could impact people who are single in ways that are different than people who are in long-term relationships. If you look at the length of the relationship too, this is where you would find some differences. So, 19% of the gay and bisexual men were in a relationship for less than 2 years versus 7% of the heterosexual men. And then another common one, of course, is casual sexual partners. So 40% of the gay and bisexual men had casual sexual partners versus only 4% of heterosexual men. Now, if you looked at their sexual quality of life outcomes, how people reported it was that the gay and bisexual men actually had a little bit higher sexual quality of life outcomes compared to the heterosexual men. So that's interesting, and that has also been found in other studies as well. Part of me thinks this is because gay and bisexual men are just more sexually active. But they did find that there was much more psychological distress in the gay and bisexual men. There was more cancer-related distress and anxiety among gay and bisexual men. There was much more concerns about ejaculatory function. So once the prostate is removed or the prostate is radiated, there really is not any ejaculate anymore. And this occurs with both treatments. And it can be something that is particularly concerning for some people. Heterosexual men too, but it is more of a complaint among gay and bisexual men. And then if you looked at satisfaction with treatment, it was worse among gay and bisexual men. So study number five is the Restore survey. Restore is a big study, and we're going to talk about there's a Restore 1 and a Restore 2, and we're going to talk about both of them. And this group really has done probably the most amount of work in this area. So big kudos to them. And this was another survey-based study, but it was slightly larger than the last survey. And it was specifically among a group of people who were recruited from this website called Male Care. And it is a website that you should check out if you were recently diagnosed with prostate cancer. And it's a large cancer support group. And they support about 800 to 1,000 new diagnosed gay and bisexual men each year. And this study, which was published in 2019, is from a large survey of 193 men from this male care organization. And the title of the study is The Sexual Functioning of Gay and Bisexual Men Following Prostate Cancer Treatments, Results from the Restore Study. One other comment I wanted to make here is that 800 to 1,000 people are getting some sort of support from this website, but only 193 are in the study. So is this a selected group? And how are these 193 people different from the 800 to 1,000 people? We don't know. One thing I think we need to work on, though, is improving and increasing enrollment in research studies because we are not going to really come up with the answers unless we are reaching more people. But here are the results. So, when measured via traditional surveys, again, gay and bisexual men scored higher on sexual functioning than published norms, okay? And that was the same as that other study. But this study did highlight some kind of new concerns that were kind of the first time to acknowledge some of these things. One is involuntary urination during arousal and climax. And this is really particularly bothersome for some people who are not into water sports, okay? When people get aroused after the prostate is removed, and sometimes when it's radiated, there can be some leakage of urine during that time. This was another study that first highlighted issues with bottoming. So there was some anodyspareunia, which is sort of severe pain with bottoming that prevents bottoming for a lot of people, and anorgasmia during bottoming. So meaning that they patients just really could not orgasm during bottoming like they did previously. Another interesting finding was that there were three patients out of the, how many were there again? 193 that did seroconvert with HIV post prostate treatments. And there's a lot of theories about why this is, but I think most of them are likely just social in that, you know, either people are engaging in more risky sexual behaviors and or there's this idea that, oh, you can't wear a condom anymore because your erection is not hard enough. And maybe there was some seroconversion there, but or it could just be a baseline thing that maybe this would have happened regardless if people got treated for prostate cancer or not. But it was an interesting, finding that the authors talked about. Study number 6 is that I call this the challenging traditional surveys, and this was published in LGBT Health. And, when you go to your urologist and or radiation oncologist office, they're likely going to give you some surveys to fill out. And there's surveys about urination, about sexual health, about quality of life, all of these things. And what a lot of gay and bisexual men were realizing, and again, this is over the course of the last 20 years or so, was that these surveys don't necessarily really capture the gay and bisexual experience. They're very kind of heteronormative. And if all of the big prostate cancer trials are publishing on these surveys that are kind of heteronormative, it leaves the gay and bisexual population in the shadows. And this was a really good study, a pilot study assessing aspects of sexual function predicted to be important after treatment for prostate cancer in gay men. And an underserved domain highlighted. And this is a pilot study of 53 gay and bisexual men assessing the relevance of the EPIC sexual function questionnaire. So the EPIC sexual function questionnaire is a common, probably the gold standard questionnaire to determine how good people's sexual function is before and after. And this group basically asked these men, is this applicable? Question mark. And 75% found that the EPIC was applicable to erectile function, but it missed questions about masturbatory function and quality of orgasm that they thought was important. I often think, gay men have a sort of large sexual appetite in that they've usually been in many different types of sexual experiences. And so they kind of know more, I think, sometimes of when something is functional versus dysfunctional. And this is what they were looking at these traditional surveys, and they're like, well, there's a lot of things that might be kind of missing here that's important to me. Number two is that the majority felt that the prostate was a source of their pleasure. And the epic does not address bottoming at all whatsoever. And there's really no validated instruments at that time to assess sexual function related to bottoming. Study number seven, this is actually one of my own studies that I included in here. I'll call this the Atlas study. And this was the Atlas of Receptive Anal Sex Experience Among People with Prostates. And the whole purpose of this study was to understand, this is a little bit of a segue from prostate cancer, but it does relate, just follow along here, is to understand what is the source of pleasure during bottoming and how do people also experience pain. And the purpose of this study was so that we can start to build a questionnaire, which we now do have, about sensations that people experience during bottoming, so that we can better figure out how do treatments impact it. But anyways, this was a qualitative study of 30 individuals assigned male at birth who participated in bottoming. And one thing we found was that there was a whole host of sensations that people liked to experience, and it really mapped out along with the nerves that are sensory nerves that are in the pelvis. So again, when the prostate and bladder kind of hit during bottoming, people say it feels like this massage, a tingle, almost like an electric sensation. There also can be sort of radiating sensations. Another group of people just really like the stretching of the anal sphincter and the pelvic floor muscles, and people like that stretching, that relaxing and contracting. It felt like a tingle, a warmth, etc. So the reason why I bring this up is that we are finding that there are kind of different phenotypes for bottoming, and people like different sort of sensations during bottoming. And I want to point out the following quote because we did have one person in the study who had his prostate removed after prostate cancer, and this is what he said. I think this is really important. It's interesting because for the last 9 years out in the gay world, I've heard people say, oh, he hit the prostate, massage the prostate, the G spot. I had a lot of fun, enjoyed a heck of a lot of times, and still do. This he was talking about before he had his prostate removed. But I do not remember anything specifically feeling in that area, meaning around the prostate. I guess it's lucky enough because now I do not have one and I did not lose anything. And I was with enough partners that certainly they would have hit it. And this was kind of a groundbreaking quote for a lot of us because everyone thinks that the prostate is the G spot for the male, but it is not for everybody. And here's a good example because he had his prostate, bottomed, enjoyed bottoming, and he enjoyed bottoming just the same after the prostate was removed. And he was one who had said, I just enjoyed the muscles separating, the rectal fullness. So there are sensations that you can get from bottoming that has nothing to do with the prostate because again, his prostate was removed. And one thing that I think is important is that the prostate is just a gland. What produces sensations is typically nerves. And there are a lot of nerves that wrap around the prostate. Now, there are also people who've had their prostate removed and say that the sensation is dulled for them, meaning that they don't get quite the same sensation during bottoming as they once did before. So I think there needs to be more research in this area to kind of figure out, who is really going to be impacted the most by removing the prostate versus radiating the prostate. But I thought this was an interesting quote. Study number 8 is this change in role in sex. And this was a very interesting study that looked at how people self-identified, top versus bottom, etc., before and after prostate cancer treatments. And this one I find to be a really important and just interesting study, and it's the effects of prostate cancer treatment on role in sex in gay and bisexual men. Mixed methods results from the Restore 1 and Restore 2. So this is actually, but we haven't talked about Restore 2 yet, but this was a secondary analysis. So they combined the results of the Restore 1 and Restore 2, and they specifically just looked at this idea of change in role in sex after prostate cancer treatments because it is a common phenomenon that occurs. So let's get to the results. So don't look at all this stuff yet. It's a little bit messy, but this is year prior to diagnosis. What did they say that they were? So exclusive top, versatile top, all the way down to bottom, etc. And then this was last 4 weeks. So this is after their prostate cancer, treatments, etc. So you can see exclusively top. There were 94 people who were exclusively top before prostate cancer treatments. And you can see that after prostate cancer treatments, 12% of them were now exclusively bottoms, 3% were verse bottoms, 2% versatile, 5% were verse top. So there's a big, change in people who are exclusively top after prostate cancer treatments. And why is that? Well, there is changes in erectile function, and some people find it easier to bottom than to top. If you look at now, of course, there is a good amount of missing data here. So I think that's a caveat, a little asterisk you should put to it. But just look at the trends in general. So again, 79% were versatile tops before treatment. And again, a good portion were versatile bottom, exclusively bottom. So again, out of those 79 people who were versatile tops, 20%, I'm sorry, 20 of them were exclusively bottom after prostate cancer treatments. Now, so it really goes, it should, instead of just saying change in role, it should say almost top to bottom, because a lot of the main change is really going from top to bottom after prostate cancer treatments. You don't really see a lot of people who are exclusively bottom. That's 35 people prior to diagnosis. None of them are, exclusively tops after prostate cancer treatments. So, and then they ask people, like, tell me more about this. And so here's one quote from the study. I was a top. I am a top, I guess. I have been very sexually active my entire life, and it was very important to me. Losing it was just devastating. Well, right now, I kind of consider myself asexual. I'm incapable of sex. So, this is an important quote because it does show that for some people, this is a really devastating side effect of the treatment. But there is a full range of how it affects people. And, one group of people, it's like absolutely devastating. Other people, they'll say, this is a new chapter in my life. They find this new role novel and new. Other people just explore alternative forms of sex. So they'll just say, listen, I like side stuff now. I'm not really into bottoming. I never really have throughout my entire life. So I'm not going to pick it up after prostate cancer treatments. And then other people use this as a way to explore new fetishes out there that have kind of nothing to do maybe with the role of the erection. So again, this is an important thing because if you are a top currently, it is, there are some people who recover good erectile function after their prostate cancer treatments. I'm not saying that that's not true, but it is likely going to change for you in some way. And there has to be something you got to do to kind of deal with that. Okay. And there are a lot of medical things that we can do to make it better. But there are also kind of your own perspective of how am I going to deal with this and what am I going to do? So here's the Restore 2, which is probably one of my favorite studies on the list of 10. And this was published in the Journal of Cancer Survivorship. And the reason why I want to highlight this study is because this study was a randomized controlled study, which is a really hard study to pull off in that we kind of think of it as this, you know, holy grail of research. Like if we randomize people, then we can really understand, does our intervention affect our outcome? But this was a 2-year randomized controlled trial of just gay and bisexual men with prostate cancer. So again, really big kudos to this group because they have been working really hard to pull something like this off. And basically what they did was the intervention was that half of the men got almost like a bunch of information and counseling and coaching about how to deal with all the issues in prostate cancer treatment. So they got ED medication, sexual aids, pelvic floor exercise video, a guide to gay sex following treatment and coaching. Now, the other group, it's not like they didn't get any support, it's just they were the usual care. So they were just out and about, seeing their urologist, seeing their radiation oncologist. They weren't getting any sort of special treatment. And they basically followed them up and said, kind of how do they do? Again, this was 401 people who were included in the study. It's a huge proof of concept study that it is possible to do high level of evidence work with gay and bisexual men. I think one of the downsides of the study, and it was a negative study, which I'll talk about in a second, but they included men after it wasn't directly after their prostate cancer treatments. It could be almost any time afterwards. And the mean years since they were diagnosed of the people in the study was 5 years. So these are people on average 5 years ago they had their prostate cancer treated. I think if they would have maybe included people who were closer to their time of diagnosis, they may have found bigger differences, but I don't know for sure. It's hard to say. Most participants, though, had completed treatment more than 2 years ago. And there was no evidence that this intervention that they tried, it did not improve sexual or urinary outcomes. But there were some cool things in that. Here are some figures. In blue, this was the participants in the randomized intervention group, and then this is the control. And okay, so if you look at pelvic floor exercises, so these men in the intervention group were finding it to be useful, and more of them were actually doing pelvic floor exercises in the intervention compared to the control. Vacuum pump was another one. So if somebody like gave you a vacuum pump, you were more likely to be using it at the end of the 2-year period. So it's interesting in the sense that people, I think, liked these things that were given to them for rehabilitation after prostate cancer treatments. But if you looked at how they reported their sexual life and their urinary quality of life on surveys, there really was no difference between the groups. So we have more work to do in terms of figuring out what are the interventions that are really going to make urinary and sex life better after prostate cancer treatments outside of what they did in this study. And it is possible that maybe if we intervened a little bit sooner, like right after their prostate cancer treatments, maybe we would have seen more of a difference here. And then study number 10, this is a secondary analysis of that last study. I call it the treatment choice study. And it it looked at comparing prostatectomy versus radiation, specifically in gay and bisexual men. And so very interesting. And I'll just show you what they found. was so compared to RP stands for radical prostatectomy. EBRT, which is just radiation, was associated with lower rates of climacturia. So that means, peeing when you orgasm. That occurred in 11% of people with radiation versus 60% of people with radical prostatectomy. Condom-related erectile dysfunction, 27% versus 51%. I'm not a big fan of that definition, but it basically is that when you're using a condom, you get like erectile dysfunction. There was less penile length and girth, decreased penile length and girth. So when the prostate is removed, right, you have to re-sew that back together. So there can be some shortening of the penis, but it can also occur when you radiate the prostate as well. But what they're saying here is that in radical prostatectomy, that was the shortening was more severe than in radiation. So 49% versus 69%. But you can see almost half of people, regardless of what treatment they got, there was some decrease in penile length and girth. There was higher rates of anal dyspareunia, so that's painful anal intercourse after radiation than surgery. So you can see that 33% had anal dyspareunia versus 14% in the radical prostatectomy group. Now that one may be interesting to really look at. Again, like if you look at how they defined anal dyspareunia, it's not a standardized way to kind of define that. And now I think we have better measurement tools for that. So it's interesting. I also think because there's a lot of role switching after prostate cancer treatments. I've showed you that in the other slide. So people who've been long-term tops, now all of a sudden they're bottoming. And is it really because of the treatment that they're having pain with anal intercourse, or is it because they just haven't bottomed in a really long time? And so I think there's a little bit of confounding there, and I think we'll learn a little bit more. But what the authors said from this was that these findings suggest, so this is not a hard and fast rule by any means, but it suggests that if you really wanted to preserve insertive intercourse. So you're a top and you want to be a top, you should get radiation. And if you're a bottom, you should get a radical prostatectomy, okay, to prevent pain with bottoming after radiation. So again, I think that this is just, I want to put a big caution around this study. I think it's really great question to look at and really great data to look at this side of thing, but there's a lot of unknowns here. And I do not think that your whatever you say is your identity and your preferred role, I don't think that should be an automatic you should get radiation versus surgery. I think this is just one piece of data that can help you make that decision. So let's review some of the unique issues for MSM. What's MSM? Men who have sex with men with prostate cancer. Number one, you know, you need firmer erections to get into the anal canal than the vaginal canal. And I think we're starting to really realize that, how we defined erectile function in straight men, it's always like, oh, is it good enough to have intercourse? Well, we've realized that you don't have to have a hard enough or that hard of an erection to get into the vagina. Now, it still needs to be hard, but to get into the anus, it needs to be even harder. So that's an important point here that's different. We are now understanding that changes to bottoming can really occur. So decreased pleasure, increased pain. Again, who is this happening in? Is this because of role switching? Is this truly because of radiation? Is this because how are we measuring this? There's a lot of things I think we still need to kind of focus in on. Number three, of course, this is just a side here, more of a clinical pearl that, poppers and PDE5 inhibitors can severely lower blood pressure when used together. So there is a higher rate, of course, of popper usage among gay and bisexual men compared to heterosexual men. And I wonder how many urologists or people out there who are prescribing Cialis and Viagra are letting people know about this because it is an important thing to be aware of. certainly there is more to stress over an ejaculation. And this is something that that I don't know how we're going to necessarily fix other than having help people understand that this is a irreversible cause, irreversible side effect of treatments. Remember, the prostate gland, that is what the prostate does, is it creates these fluids. When the prostate is completely radiated or removed, there is not going to be ejaculation afterwards. Another unique issue, of course, is change in role in sex, which we've discussed. Another issue is disclosure of treatment effects. So when you are meeting a new partner or telling your, spouse or whoever, you got to talk to them. And how do you talk to them? Should you talk to them about treatment effects? And this is something that is certainly comes up a lot in gay and bisexual men after their prostate cancer treatment of how do I do this? And it often causes people to be isolated. And let's not ignore the idea that we live in a world where providers still ask you about your wife. And unfortunately, this happens all the time. I'll have people who come to talk to me and they're like, oh, yeah, they keep asking about my wife, or the questionnaire asks about my wife. And, obviously, the world is built for heterosexuals and, we're just living in it. So, but hopefully we are changing this. But I understand that there is some bias within the medical setting around these issues. So, my advice to gay and bisexual men who are recently diagnosed with prostate cancer. Number one, this may sound obvious, but it's not always. Get the cancer under control. So, I think it's important for you to see the people whoever's going to do your surgery or do your radiation. You want to find somebody who does this all the time, that they are an expert at the oncologic piece of it. Um, because if your cancer treatment fails, like you get surgery, but you have a positive margin, or you get radiation and your PSA is still elevated, the more treatments you need for your prostate cancer to get the cancer under control, the more side effects you're going to get. Now, I know some of this stuff is out of your hands, meaning that you couldn't control how your surgeon did your surgery or the radiation, etc. But what some people really sit on their cancer for a really long time, and they're pushing this active surveillance when they should be getting treatments. So it's just one of those things that I think it's important to get the cancer under control. And so seeing somebody who is a, prostatectomist, and that's all they do is prostatectomies, is really important to get their kind of perspective on your case. Another thing that came up is like, should I see a gay urologist? And I don't even think you should. I mean, you can see a gay urologist like me to help you with the side effects from treatments, but you want to see sort of the best cancer surgeon or the best radiation oncologist. I think that's really important. And if you need to get a second opinion from people, get a second opinion. Okay. Um, and remember, another caveat is not all cancer should be treated. So it is important to talk with your urologist and doctor to see, like, is this prostate cancer the type that can be watched? And a lot of them, that is true. Number two, before you get your cancer treated, you should see both a urologist and a radiation oncologist. You may be set on surgery, but I think it's really important that you also talk with a radiation oncologist. And you may be set on radiation, but I think it's also important that you talk to a surgeon and just hear, their experience with dealing with people with prostate cancer. Number three, this is going to be a stressful time in your life, and there is going to be some changes in your life, and in particular, your sex life. And I think the people who do the best are the ones who find support. And that can be via a support group where you talk with people who are undergoing similar things as you. It can be a friend group, it can be just an individual therapist, but finding some sort of support. But I really think support groups are really nice to be able to kind of use other people as a sounding board and for people to kind of understand kind of what exactly you are going through. Number four, before you get your prostate cancer treatments, underway, I want you to think about what is really important to you during sex. Like, what is it that if you, the um, one thing that is what's the one thing that's really important to you that you'd like to preserve? And you can dig a little bit deeper and think about why is that? And number five, participate in research. This is really important. I think we need more participants in research from gay and bisexual men in order for us to um, get the right outcomes and figure out how do we help people in the future. If we don't study people today, we're not going to be able to figure this out in the future. But ultimately, prostate cancer does not define you. And it's really more than survival. It's thriving with pride. And I just put a list of people up here who have really dedicated a good portion of their careers to not only pushing prostate cancer evidence forward, but specifically prostate cancer evidence in gay and bisexual men. And so there are some leaders in the field who are really trying to figure this out so that we can have the best outcomes possible for not only heterosexual people, but especially gay and bisexual men with prostate cancer. So thank you for listening. Feel free to put any questions or thoughts in the comments, and I appreciate it.